Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 499 of our pharmacotherapy series, which majors in anemias. The first case reads, BHP is a 31-year-old woman seen in the clinic. Her chief complaints include weakness, dizziness, and epigastric pain. She has a 5-year history of peptic ulcer disease, a 10-year history of heavy menstrual bleeding, and a 15-year history of chronic headaches. She has 2 children who are 1 and 3 years of age. BHP is currently taking minocycline 100 mg twice daily for acne, ibuprofen 400 mg as needed for headaches, and esomeprazole 40 mg daily. Her review of systems is positive for decreased exercise tolerance. Physical examination reveals a pale, lethargic, white woman appearing older than her stated age. Her vital signs are within normal limits. Her heart rate is regular at 100 beats per minute. Her examination is notable for pale nail beds and splenomegaly. Significant laboratory results include the following: a hemoglobin of 8 grams per deciliter, a hematocrit of 26%, a platelet count of 500,000 per microliter, a reticulocyte count of 0.2%, an MCV of 75 femtoliters, an MCH of 23 picograms per cell and MCHC of 300 grams per liter, serum iron of 40 micrograms per deciliter, serum ferritin of 9 nanograms per milliliter, a total iron binding capacity, TIBC, of 450 grams per deciliter. 4+ stool Guaiac, which can be considered normal or negative. Iron deficiency is determined to be the cause of BHP's anemia. An upper gastrointestinal series with a small bowel follow-through are planned to evaluate her persistent epigastric pain. So my first question to you reads, what factors predispose BHP to iron deficiency anemia? Several factors predispose BHP to iron deficiency anemia. Her history of heavy menstrual bleeding and the 4+ stool Guaiac indicate menstrual and gastrointestinal sources of blood loss. The gastrointestinal blood loss may be secondary to BHP's chronic use of non-steroidal anti-inflammatory drugs, recurrent peptic ulcer disease, or both. Many women of childbearing age have a borderline iron deficiency that becomes more evident during pregnancy because of the increased iron requirements. BHP has given birth to 2 children. Therefore, her iron stores have been repeatedly taxed in recent years. In addition, absorption of dietary iron may be compromised by her use of proton pump inhibitors and minocycline. My next question to you reads: what subjective or objective signs, symptoms, and laboratory tests are typical of iron deficiency in BHP? BHP's constitutional symptoms of weakness and dizziness could be a result of her severe anemia. Generally, until the anemia is severe, such symptoms occur with equal frequency in the non-anemic population. The most important signs and symptoms of iron deficiency anemia are related to the cardiovascular system and are a reflection of the imbalance between the ongoing demands for oxygen against a diminishing oxygen supply. BHP's increased heart rate, decreased exercise tolerance, and pale appearance are consistent with tissue anoxia and the cardiovascular response that may be seen in iron deficiency anemia. BHP's iron deficiency has advanced to symptomatic anemia. In patients who are not yet symptomatic, however, depletion of iron stores can be detected by measuring ferritin, the iron storage compound. Although ferritin is primarily an intracellular protein, serum concentrations of ferritin correlate closely with iron stores with only a few exceptions. Ferritin, an acute phase reactant, is generally found in higher levels in patients with inflammatory disorders, infection, malignancy, liver disease, and chronic renal failure. BHP has a serum ferritin level of 9 nanograms per milliliter. Less than 12 nanograms per milliliter is consistent with iron deficiency. An increased total iron binding capacity also can reflect depletion of storage iron, but it is less sensitive than serum ferritin. Thus, in iron deficiency, the serum ferritin concentration is low, whereas the total iron binding capacity is usually high. Both of these parameters can be detected before the clinical manifestations of anemia are apparent. These abnormalities persist and worsen because anemia develops as illustrated by BHP's laboratory values. If the total iron binding capacity is low or normal, rather than high, in association with a low serum ferritin, other causes of anemia should be considered and evaluated with additional labs and bone marrow examination. BHP's low serum iron, low serum ferritin, and elevated total iron binding capacity are typical of the laboratory findings associated with iron deficiency anemia. Serum transferrin receptor levels, which reflect the amount of RBC precursors available for active proliferation, are increased in iron deficiency. After stored iron is depleted, Heme and hemoglobin synthesis is decreased. In severe iron deficiency, the RBCs become hyperchromic, as shown by the low MCHC, and microcytic, as shown by the low MCV. Usually, the RBC indices do not become abnormal until the hemoglobin concentration falls to less than 10 grams per deciliter. BHP's corpuscular indices indicate that her anemia is hyperchromic and microcytic. The reticulocyte count provides an estimate of effective RBC production and is usually normal or low in iron deficiency anemia. BHP has a reticulocyte count of 0.2%, which also is compatible with iron deficiency anemia. In the workup of a microcytic, hyperchromic anemia, the stool should be examined for occult blood. BHP has a 4+ stool guaiac, which suggests blood loss via the gastrointestinal tract. Further diagnostic evaluations, e.g., endoscopy, abdominal X-rays, are necessary to determine the underlying problem. In summary, BHP's signs, symptoms, and laboratory findings all support the diagnosis of an iron deficiency anemia. My next question to you reads: how should BHP's iron deficiency be managed? What dose of iron should be given to treat BHP's iron deficiency anemia? The primary treatment for BHP should be directed toward control of the underlying causes of anemia: gastrointestinal blood loss, multiple childbirths, heavy menstrual flow, decreased dietary iron absorption, and perhaps an inadequate diet. The cause of her gastrointestinal blood loss should be corrected, her dietary intake should be analyzed and modified, and supplemental iron should be prescribed to replenish her stores and correct the anemia. The usual adult dose of ferrous sulfate is 325 mg, corresponding to 1 tablet, administered 3 times daily between meals. However, because of limited absorption of iron in the intestines, repletion with lower doses of iron has been shown to be effective, potentially minimizing side effects and improving compliance. If no iron is being lost through bleeding, the required daily dose of elemental iron can be calculated using a formula that assumes that 0.25 gram per deciliter per day is the maximal rate of hemoglobin regeneration. Elemental iron, in milligrams per day, is equal to 0.25 gram of hemoglobin per 100 milliliters of blood per day, which translates to 5,000 milliliters blood multiplied by 3.4 milligrams of iron per 1 gram of hemoglobin. This translates to 40 milligrams of iron per day, considering 20% absorption, which is the approximate absorption rate in iron deficiency states. This translates to 200 milligrams of iron per day, which corresponds to 1,000 milligrams of ferrous sulfate per day, since ferrous sulfate contains 20% elemental iron. This corresponds to a dose of 325 milligrams 3 times daily of ferrous sulfate. My next question to you reads: what are the differences between iron products? Which is the product of choice? The ferrous form of iron is absorbed 3 times more readily than the ferric form. Although ferrous sulfate, ferrous gluconate, and ferrous fumarate are absorbed almost equally, each contains a different amount of elemental iron that is available for absorption. Carbonyl iron, another iron product, is available, but its use may be limited owing to the fact that iron in this form must be solubilized by gastric acid to be absorbed. Product formulation is of considerable importance in product selection. Sustained release, abbreviated as SR, and enteric-coated preparations may increase gastrointestinal tolerance or decrease side effects, increase bioavailability, and also may have additives claimed to enhance absorption. Because these products can be given once daily, increased adherence is an additional claim. Anecdotal claims that sustained-release iron preparations cause fewer gastrointestinal side effects have not been substantiated by controlled studies. These products transport iron past the duodenum and proximal jejunum, thereby reducing the absorption of iron. Because poor absorption and poor hematologic responses might occur with sustained-release formulations, caution should be used if chosen for initial treatment. Adjuvants are incorporated into iron preparations in an attempt to enhance absorption or mitigate side effects. An acidic environment is needed for absorption in the duodenum and upper jejunum. Ascorbic acid, also known as vitamin C, given in doses up to 1 gram, is able to increase iron absorption by approximately 7%. However, smaller doses of vitamin C, e.g., 25 mg, do not significantly alter iron absorption. To decrease the side effect of constipation, stool softeners are also sometimes added to iron preparations. The stool softener dose may not be appropriate and additional doses may need to be taken. In summary, BHP should take the least expensive iron preparation containing ferrous sulfate, gluconate, or fumarate. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 500.